In this lecture, I'm going to talk about immunotherapy for psoriasis with a special focus on biologics treatment or biologics drugs. And as you may know that biologics agents or medication or drugs are newer and they are stronger medicines. A biologic can target or quiet only the part of the immune system that is overactive because of the psoriasis. This means that biologics have less risk of causing problems with the liver, kidneys, and other organs. But however, first I will give an account on the treatment or the conventional treatment or the traditional treatment or the standard treatment for psoriasis. And the traditional treatment for the psoriasis for if a patient diagnosed for the first time and if the condition is not that severe, so we put usually the patient on topical creams, corticosteroids, cyclosporine or retinoids, and phototherapy. And also we use methotrexate. It is an immunosuppressant and it is used commonly for moderate to severe psoriasis in adults and pediatrics. So we can use it in adults and pediatric with good efficacy and should be supplemented with folic acid just to reduce the side effect. And usually we give methotrexate twice per week. And also we give Mycophenolate, and it is widely used with less complication. It is an immune suppressant and could be therapeutic option for psoriasis. But however, the traditions or traditional treatment option may actually with time may lose their effectiveness and may often don't work well enough for those with moderate to severe cases. So accordingly, the American Academy of Dermatology suggests taking a biologic agent if the patient has moderate to severe psoriasis, but however not responding to this treatment, and if the patient has not improved using more traditional systemic agents, and if the patient cannot tolerate the traditional treatment because of their side effects. So, and also if 10 to 20% of the body surface involved with a psoriatic lesion, so in this case we advise to start with a biologic treatment. And also in case of pustular psoriasis, also we advise to start with biologic treatment. And in patient with erythrodermic psoriasis, and this condition actually it is very serious and may be life-threatening, as the whole body may be involved and the patient may lose lots of water and may get shock. So here the advice is to start immediately with biologic treatment. And in those also suffering from arthritis due to psoriasis, we advise to start with biologic treatment. So now I will start by giving a very short account on the available biologic drugs or medicines the available one, it is we start with anti IL-1, and actually these most of them, they are monoclonal antibodies. So IL-1 antagonist, it is actually prescribed for cases with pustular psoriasis, and there are two types of it, anakinra and canakinumab. Canakinumab and anakinra, they are available now and they are in use, and they are anti-IL-1 in case of that might lead to this serious condition. And also we have biologic anti-IL-23 inhibitors, and this 23 is a cytokine, actually interleukin number 23. It has a receptor on the surface of T helper cell number 17, and actually when the anti-IL-23, when the interleukin number 23 residing here in the receptor on the surface of the T helper, it will activate this and will proliferate and will produce interleukin number 17 that will act on keratinocytes and will lead to proliferation of keratinocytes together with pro-inflammatory effect of that cytokine. So this actually injections of or treatment, this biologic treatment, anti-IL-23 inhibitors, when given to the patient, they come and sit here, block this receptor. So this is it has a neutralizing, these monoclonal antibodies, they have neutralizing effect, and they interfere with interleukin number 23. However, it is used for other patients also who have not been adequately managed with standard therapies, or for patients with arthritis due to psoriasis. But however, if for a patient with moderate to severe not responding to traditional treatment, we use maybe first Infliximab. Infliximab, these are monoclonal antibodies, and these antibodies actually they are anti-tumor necrosis factor, anti-TNF, and as you know that TNF, it comes from macrophages and other cells, and this TNF may lead to destruction of tissues and of cartilage, maybe of bones in case of arthritis, and so when we give the infliximab for at least 6 months, and the response is not that dramatic response, so we can shift to guselkumab. So guselkumab, now it is available, and this guselkumab, it is actually IL-23 inhibitor. Guselkumab, it is now actually available and in use. So now let us go for as I mentioned before, that T cells or T helper 17, maybe other type of T helper of T cell known as gamma delta cell, and the mast cell, they produce some cytokines, or namely interleukin number 17, and actually this cytokine is a pro-inflammatory, and it will lead to proliferation of keratinocytes. So this can be given for black psoriasis. Black psoriasis means it is raised, the lesion is raised actually, and actually 80 to 90% of psoriasis is black psoriasis. So this is very effective in case of plaque psoriasis, and bimekizumab now it is available and very effective in preventing this interleukin number 17. So it will come and sit here, interfere with interleukin number 17. And now let us come to tumor necrosis factor, tumor necrosis inhibitors. Actually, it is known, it has that approved, Infliximab approved 2006, and it is in use since 2006, and it has an anti-inflammatory. We use it in many autoimmune chronic inflammatory disorders, and however, for psoriasis we prescribe it for severe psoriasis, and this is tumor necrosis factor. It comes, for example, from macrophages and monocytes, and actually the injection of this infliximab provides significant improvement in patients with psoriasis. However, nowadays we have certolizumab, which is TNF inhibitor used to treat moderate to severe plaque psoriasis in adult patients, including women of childbearing potential. Childbearing potential means that a woman that she has a capacity to get pregnant, but stops that by, for example, getting contraceptive pill or to any other reason. So if she gets psoriasis, she can get this type of treatment, and actually it is indicated also for the patient with psoriatic arthritis. So now let us come to neutrophils. So we have now recently we have some reports, recent reports indicated that the oxidative stress and the granular components and neutrophil extracellular trap from psoriatic neutrophils are related to initial and maintenance phases of psoriasis. However, as can be seen here, this is a macrophage, the neutrophils, and during the psoriasis, these neutrophils actually infiltrate the keratinocytes, and they are present in very large amount, and they get activated, and during this activation they produce reactive oxygen species and myeloperoxidase, and in addition to that they modify the chromatin, their chromatins like this, and they express some filaments or traps or fibers like this, or threads, which are very sticky, and actually they play a role in immunopathogenesis and maybe increase the severity of psoriasis, and these traps actually may work good in case of infection, may trap the infecting agents, but unfortunately it may also trap platelets, and this may lead to deposition of fibrin with formation of thrombus. So these fibers, we call them neutrophil extracellular traps. So however, nowadays they are thinking, or we with them thinking, that targeted biological treatment may aid in the containment of sustained neutrophil mediated inflammation. Thank you very much, Professor Ahmed Borat.